you, Bill. Everybody can hear me clearly, loud enough? Perfect. Thank you and welcome this evening, and thank you for attending. So I'm going to give a talk today explaining and discussing a bit about something recently we've started offering at Desert Cardiology, something that, is often under-recognized and undertreated, and that's chronic venous disease and the options that are available to patients for diagnosis, evaluation, and treatment. So a bit about the disease itself. Chronic venous disease is a very common medical problem. We know now that it causes significant morbidity and mortality in patients. As I mentioned earlier, it's often under-recognized, and for that reason, it's not treated often. There's a very wide clinical spectrum of this condition, and it goes from cosmetic issue to something very distressing for the patient, causing significant morbidity, which is venous ulcers. And I'll go through a bit more of those subtopics in a bit more detail. So prevalence of this disease, approximately 175 million Americans have chronic venous disease. Out of that, about 100 million people have stages C2 to C6, and I'll explain those stages a bit more later. One of the key things to remember is this is a progressive disease, which means it tends to worsen with time if you don't start treating it either supportively or with intervention. In terms of healthcare costs, it is estimated it costs the US system, healthcare system, approximately $30 to $90 billion addressing chronic venous disease or treating the complications of chronic venous disease because it's not treated appropriately. It's far more of a medical issue than just a cosmetic. And I'll be very honest, I was skeptical of this in my training and even up until a couple of years ago, because as a cardiologist, we focus mostly on the heart. But, we are both certified cardiovascular specialists. So we look into the legs too and the carotids. But, the tendency for most of us is to focus on the box, the heart, and we forget sometimes the legs and the rest of the body. So a lot of our patients in our office tend to go outside Eisnehower and Desert Cardiology for evaluation of venous disease, and they didn't have any good resources. So this is something we, in the last few years, thought of looking a bit more deeper into and offering for the patients at Eisnehower. So in terms of some risk factors for this condition, so it's very well known your venous system tends to degenerate or deteriorate with age. So the older you get, the more likely you're going to have chronic venous insufficiency or venous disease. A family history is very relevant. You hear about mom, dad, cousins having varicose veins, venous issues tends to run in families. A history of clots in the legs, something called a deep vein thrombosis, and I'll explain that a bit more later. Something called phlebitis. So phlebitis is when, say you had an IV in a vein for IV fluids or medication. Sometimes that IV can get inflamed and get infected, but it's superficial phlebitis. That can actually eventually, if it keeps getting worse and not treated, cause venous disease down the line. Being overweight puts more pressure on your abdominal cavity. And when you have pressure in your abdominal cavity, it goes to your pelvic veins and the veins down your leg. Occupations where people are standing for prolonged periods or even seated for prolonged periods, you increase the force of gravity on your legs, on the blood column in your veins, and it can cause venous disease. Women are particularly prone with multiple pregnancies because every time you get pregnant, the uterus enlarges and it sits on your pelvic veins, and that puts pressure in the veins. Female sex, for that reason, has a higher risk of venous disease. And then, like most conditions and diseases we see, smoking has a high risk of chronic venous disease because it damages the venous lining. Some of the symptoms and signs of chronic venous disease. So from a cosmetic perspective, I think all of us at some point have seen spider veins. Spider veins are, if you look at your skin, you see a little central spot and like little spiders, red blotching around it. That's mostly a cosmetic sign of venous disease. It doesn't really cause, at that stage, any significant medical issues or morbidity. However, that can progress. And the next stage you see is something called varicose veins, prominent, dilated, distended veins in your legs. What are the symptoms people get when you have varicose veins? So heaviness, people may say, some of the things I hear from my patients is, I feel like I'm walking in sand. My legs feel like they're heavy no matter what I do. Discomfort and pain. Towards the end of the day, my legs are aching, my thighs are hurting, my calves are hurting. Swelling, I've noticed that my shoes get tighter. In the morning, my legs look okay. By evening, afternoon, I have swollen legs. Muscle cramping, and that's a very difficult symptom to tease out because we live in the desert. Dehydration causes muscle cramping. A lot of patients are on medications. I'm a cardiologist. I use a lot of statins. We know statins cause cramping. So we forget sometimes to think outside the box. Could this actually be venous disease and not dehydration or medication? Numbness and itching. Again, a lot of patients have neuropathy. So we think of that only and we forget to think about, okay, could this actually be venous disease and not just neuropathy that's not responding to medication? Changes to skin color. I'm sure you've seen friends, colleagues, family who have discolored ankles. The ankles look more browner, more darker. That is a sign of venous disease. And then finally, the dreaded complication that we all want to avoid is skin breakdown. If your leg is swollen and it causes pressure in your skin can actually start tearing. When that skin gets torn, it doesn't heal very well, and then you get venous ulcers. In terms of the classification, there's a system we use, and it's based on clinical, which means what it looks like. Etiologic means the cause of it. Anatomic means the location, and pathophysiology means the mechanisms behind it, okay? So C0 means there's no visible or palpable sign. So your legs look perfectly normal. If I do a scan and I look, I will see some reflux or some regurgitation in the legs, but there's no symptoms or signs and you don't notice it from outside. C1 is spider veins. That's the earliest sign of venous disease. C2 is varicose veins, those distended big veins in your leg. C2R is when you have recurrent varicose veins that keep getting worse. Edema means swelling. So if you start swelling in your ankles, in your calves, that's C3. And then C4 has multiple stages. The initial stage, when you have changes to the skin color, we call it venous eczema. It basically looks like your skin is brown in color, and I'll show you a picture of that afterwards. The next stage is something called lipodermatosclerosis. That is when your skin feels thickened and fibrous like a leather. And then C5 is an ulcer, C6 is recurrent ulcers. So C1 there is simple telangiectasias, which is the medical term for spider veins. C2 shows you some prominent varicose veins, and you don't have to have such prominent veins. It could be subtle varicose veins, and that's still a sign of venous disease. This is obviously a very obvious case of it looks like a snake in a person's leg. That's a very prominent varicose veins. Edema means you see the difference in the leg sizes. Clearly one leg is much more swollen than the other. And there's another condition that causes edema. There's something called lymphedema. Lymphedema is not from issue with the veins. It's an issue with drainage of lymph nodes. One of the differences with lymphedema is lymphedema involves your toes. You will see swelling in your toes. If it's venous disease, you don't see swelling in your toe. You see it most in your ankle and above. Okay, that's one of the ways we differentiate that type. And lymphedema is a very difficult condition to treat because it's lymph nodes. There's only a very few places actually treat that. Cedars-Sinai has a place where they actually transplant lymph nodes into your body to helps drain the supply. So classification further. So C4, you start seeing the skin changes. You see up here, skin looks more lighter. Down here, it's more darker. This is that lipodermatosclerosis. You see, it looks shiny. It looks shiny and fibrous. Then this is a healed ulcer. This is a recurrent active ulcer. Venous ulcers. I'm going to talk a bit about venous ulcers because it's quite relevant. And this is one of the reasons I actually was drawn to treating venous disease, because I started seeing a lot of patients in my practice with venous ulcers, and they were not having many good resources or outcomes. Initially, most of us thought most ulcers in your leg were from arterial insufficiency. So people with blockages in the arteries. It turns out that actually majority of the ulcers in your leg are venous in etiology, issues with the veins, not the arteries. It is approximated roughly 4.8 million people in the US have venous ulcers. The difficult thing with this condition is if you don't treat the underlying cause of the ulcer, you can have wound clinic, wound healing, medications. It just keeps recurring because the underlying pressure issue is still there. Some key differences between the venous ulcers and the so-called arterial ulcers. So in a venous ulcer, your skin is hyperpigmented. You get those dark brown reddish spots. In arterial, it looks pale because there's no blood supply. It's not an issue with drainage, it's an issue with supply. Location, arterial ulcers are mostly on the foot. You'll see it on the undersurface of your foot, on the ball of your foot. Venous is usually never on the foot. It's mostly ankle and calf region, because that's where when you are standing, that's where most of your pressure is at the level of the foot, above the ankle. In terms of the wound edges, venous is very irregular. Arterial is very defined. It's almost like a punched out lesion. It's like somebody took a coin and punched it out. Edema, venous disease has edema. Arterial disease does not have edema. Temperature is a very important clue to try and figure that out. If you have an issue with your arteries, so arteries supply blood from your heart to the rest of your body. Artery is away, A for away from your heart, okay? It's the good oxygen. Is the vessel that carries the oxygenated blood from your heart to the rest of your body. Veins or the venous system is what brings it back. So that vessel collects all the used up blood from your body, from your head, from your neck, from your legs, all the organs, and drains back to the right side of your heart. And it gets oxygenated from the lungs and then back through the arterial system. So if you have a poor arterial system, the blood flow from your heart away from the heart is not very good. So your feet will feel cold because the blood supply is not enough. If it's not draining enough, you have blood pooling and sitting there. It gets congested, so it feels warm to touch. And that's why when the pulses in somebody with arterial disease, when you feel their pulse in the leg, the pulse feels weak or absent. In people with venous disease, the arterial pulse feels perfectly normal. A bit about the venous anatomy. So the venous system in your leg, the system that carries blood from the body back to the heart, the used up deoxygenated blood, is composed of 3 types of veins, okay? There's a superficial veins. This superficial means right below the skin, usually in the layer under the skin in the muscle fascia. Fascia is a word which means it's the lining above a muscle. You know, if you look at beef or steak, you see there's sometimes a shiny layer about the muscle fibers. That's fascia, okay? So the great saphenous and the small saphenous vein are 2 of the most important superficial veins in your body, in the sense they are the culprits for chronic venous disease. Those 2 are the veins that cause venous disease. In addition to the great saphenous and the small saphenous, there's something called the accessory vein that sometimes connects those 2 layers, okay? Then the deep veins are deep in your leg. They are in the muscle, deep to the muscle fascia, usually in between the muscle or in the muscle itself. This you probably heard of, again, people, friends, colleagues with blood clots in their legs. That's deep venous thrombosis is a blood clot in the deep veins. So the femoral, popliteal, and the tibial. Those you need to treat with blood thinners. A superficial clot is you get an IV or a PICC line, you get a clot, that's a superficial clot. You don't have to normally treat that, it goes away on its own. Deep clot in your leg, deep system needs to be put on anticoagulation for 3 to 6 months. So the deep veins usually don't cause venous disease because it's deep to the system and those veins are a bit more robust. They don't start leaking as quickly as the superficial veins. Perforated veins are interesting because they actually connect the deep and the superficial system. And they tend to cause more ulcers than any other veins. Because if the perforator is incompetent, it causes a high pressure system from your deep to come to the superficial into your skin and break down the skin. Bit about the anatomy. So this is called the common femoral vein. Okay. So this comes down from your heart all the way down, IVC, and then comes down to the common femoral vein. This junction here is called the saphenofemoral junction. That's important, a landmark, because that's where your femoral vein becomes your great saphenous vein. So when I look for patients with venous disease, you have to prove that this junction here is incompetent or there's a leak or reflux of blood flow. Normally, blood should be going up this way. But if this is not working well because the valve here is non-functioning or damaged, you will start leaking blood back down. And the great saphenous vein goes all the way from your upper thigh. This is your groin crease. We call that the inguinal ligament. It goes all the way down and goes below your knee, all the way down into your foot. This is an accessory vein. And then this is your deep veins. So deep veins are your common iliacs, your common femoral, your popliteal, which is at the level of the knee, and your peroneal. These don't cause chronic venous disease. These cause deep vein thrombosis, different entity completely, okay? So the venous system is very large because it has to drain your entire body, all the tissues, all the organs, and bring the blood back to your heart. But it's very low pressure and very low resistance because it has to go against gravity. So there can't be high resistance in the system. It has to overcome the pressure induced by gravity and the column of blood from your heart to your leg. So how does blood flow go up from your feet towards your heart against gravity? Two important components. One is the venous valves. So if you took out somebody's vein, if you surgically removed it and cut it open, you will see valves in that vein. Every certain distance apart, there's a valve that opens and closes. When blood comes up, it'll close and hold it there. Next stage, next stage. If those valves stop working, blood starts pooling down. The second system is your venous pump. That's your calf muscle. So if your calf muscle is weak because you've been sick, you've been deconditioned, or you have an issue with muscle strength or muscle weakness, again, that pressure to pump the blood up through the veins don't work. And that leads to edema, swelling, venous disease. I'm going to divulge a bit here and talk a bit about, I think Bill had mentioned for me to say something about vein harvesting. So you've heard of people having open heart surgery. They use some certain parts of the great saphenous vein, usually the parts below the knee. And the vein has valves in it. So if you put that into your heart, it's hard to get the blood into the heart. So what the surgeon does is he will actually surgically go, remove that vein, they turn it upside down. So the blood goes down without any issue, okay? That's one of the surgical uses of great saphenous vein is for bypass surgery. And I'll talk a bit more about that later. So a bit about the pathophysiology. So what causes this chronic venous disease? The medical term is called venous hypertension. Hypertension generally basically means high pressure, right? When you say somebody has high blood pressure, you say they have hypertension. So venous hypertension means there's high pressure in the venous system. Your venous system is not designed to stand high pressure. It's not. So if you give it recurrent high pressure, what happens? It starts failing. The valves stop working and affects the calf pump, and the veins start dilating. Reflux means reflux, regurgitation, leaking, all means the same thing. Instead of the blood going back up, it starts going back down and allows blood to pool in the leg. And that causes dilation of your veins, causes inflammation of your skin, fibrosis of your skin, edema, and then ulceration. This is a schematic representation of a healthy vein. So this is a healthy vein, and these are those valves. So each pump, the blood goes up, can't come down. Next pump goes up. When you have a diseased valve, everything's open. It just starts coming down, pooling, and opening up. So the venous valves play a big role in chronic venous disease. So how do we assess a patient, or what do we look for? So, taking a detailed history to try and guide us as to do they have a risk of venous disease. So when I see a patient in my office with swelling, the referral says patient wants to see me because of swelling in their legs. Is this swelling due to congestive heart failure because their heart's not working? Is the swelling due to kidney failure because that causes swelling? Is it due to liver failure? Is it due to lymphedema? So having a detailed history is very helpful because if they have a family history of varicose veins, if their job involves standing, if they've had prior blood clots in their leg, those are all clues that we look for in the assessment. Symptoms: heaviness, walking in sand, fatigue, tired, cramping, all again red flags. On examination, the pictures I showed you, I look for prominent veins, dilated veins, skin discoloration. If you have a high suspicion, we recommend our colleagues in medicine in the hospital to refer it to an experienced physician who knows how to treat these conditions, because it is not treated often. Most people just say, our legs are swollen, keep them up, and that's all we can offer. So how do we diagnose this? So say, I have a clinical suspicion this person has this, but now I have to prove it and tell the person, yes, I have confirmed that your veins need treatment, or your veins would benefit from treatment. The mainstay of treatment is ultrasound imaging. Ultrasound uses sound waves to go and get pictures of organs or of blood vessels. So what we do is we have the patient lay flat on a table and use an ultrasound probe to look at their veins all the way from their thigh down to their leg. We know normally the vein blood flow should be going back up. So if the blood flow is leaking, it looks abnormal. So on this study here, okay, the blood flow should always, on this schematic, normal blood flow should be this way, below this. So this part tells me that this person has a reflux, and it's quite a big reflux. And we measure that in terms of something called a reflux time. That's the medical terminology to say your blood in that vein is leaking down for this amount of time. Duration of reflux. A reflux time more than 0.5 seconds is abnormal. It confirms that vein or that valve is not working normally. So the longer your reflux, the more swelling or the more pressure in the system. So treatment modalities. So supportive therapy. So sometimes I see some people who have insufficiency or chronic venous disease, but they have zero symptoms. They say, Doc, I have a bit of swelling, I have no pain, nothing whatsoever. You don't have to treat that person because they have, when you treat this condition for medical reasons, you have to justify an improvement in a symptom. If it's trace edema and not bothering them, if they have no edema, just some cosmetic spider veins, I tell them usually exercise your calf. If you're seated, pump your calf. If you're traveling long distance, get out every hour, every couple, and walk. Elevate your legs when you're at home, keep your feet up, and as much as you can wear compression at home. If they have any symptoms, pain, edema that's not acceptable for them because it's causing pain, then you need to consider treating them. Back in the day, 10, 15, 20 years ago, the mainstay of treatment was surgical stripping. a vascular surgeon or a general surgeon would go in and actually cut open your skin, go find the veins and remove the entire vein. Okay. That fell out of favor because of complications, infection, and also for whatever reason, when you remove the whole vein, some of the branches got affected and people got more swelling 15, 20 years down the line. Okay. So now we do something different called ablation, which is done two ways, either with radio frequency, which is a heat signal, or a laser ablation. Of the two modalities, radio frequency is the most popular. Then there are some other neat ways they do treatments, and that is mostly for cosmetic purposes. So, people who have little spider veins, you can do something called sclerotherapy, where they little inject a bit of white. It's a sclerosing agent. It basically makes that vein collapse. Okay, but for big varicose veins that cause discomfort, pain, or complications, ablation is the preferred treatment. Okay. So in terms of the radio frequency ablation, what does it entail? So it's minimally invasive procedure. And essentially what you're doing is you're giving heat to that vein to collapse the vein. Okay. It's best for large veins. So the great saphenous, the big one that runs all the way down, and the small saphenous vein are best treated this way. There is another procedure that other people use where they actually inject a certain glue that goes all the way and closes it off. The results, I would say, both are equivalent. The technique used is dependent on the person doing what they feel more comfortable and what they were trained in. In terms of criteria, when I scan a person and I look at the images, for the vein to be successfully ablated, it has to be more than 5 millimeters because I have to get a wire into that vein. So if the vein is too small, I can't treat it. Likewise, if the vein is too big, because it's been going on for 15 years and was never treated, you can't get a good outcome. You can ablate it, but it may not close up completely. So they may not have complete resolution. So I tell people who come and see me, I saw one gentleman today who had literally like stakes on both his legs. And I told him, you will get some relief of the swelling and the pain, but visually your veins may not disappear. You will still have some because it's so big that the ablation won't be completely successful. In terms of medical indications, so like I said, cosmetic purposes, you can people treat for any stage, okay? Because it's cash pay, you don't need medical justification for cosmetic treatment. If somebody doesn't like the way the Spider-Man look, they inject it, it's done. So right now in our practice, we're only doing medically justified venous therapies. So that's level C2 to C6, so edema and beyond. Edema, pain, discoloration, ulcers, you qualify. Medicare approves it, private insurance approves it. If you prove with the symptoms, the images confirm the right size of the vein, so the vein's large enough, and there's enough reflux. Then they will agree that, okay, the patient's symptoms or the patient's edema are due to this, and treating that will make the patient's symptoms get better. So on this picture, if you notice, so this is the vein, this is my catheter in the vein. And what we do essentially is we give a heat signal and we burn that vein and collapse it. By collapsing it, you don't get the pressure buildup in the superficial part of your leg. How is the procedure done? This is an outpatient office procedure. We don't use any sedation or anesthesia. Obviously, sometimes I have patients who they say they would like something to calm their nerves. So if that's the case, we'll give them either some Valium or some Ativan, but they have to have a driver drop them and pick them up. Normally for this procedure, they drive to their appointment and drive back home. You can eat and drink normally and no sedation. We do one leg at a time, and the reason for that is we use numbing medication, something called lidocaine, to numb your leg. So if you give a lot of lidocaine to a person on both legs, because it's a big area, you can sometimes get it into the systemic circulation, and that can be not comfortable for the patient. After the procedure, we have the patient walk. So every hour we tell them to get up for a few minutes, 2 minutes up and down. And the first 24 hours after the procedure, we have them compress it significantly with bandage and a compression stocking. Keeping that compression on even beyond the 24 hours makes a big difference to the outcome. Because if I collapse the vein with the ablation catheter, the chances that vein will stay collapsed is much higher if you've been compressing your leg so there's no buildup. So that means once we remove your bandages in 24 hours, we recommend compression stockings for the first 2 weeks when you're at home. You can remove them at night because you're laying flat, so there's no gravity, okay? In terms of complications, every procedure we do has certain risks. So likewise, if I am putting a needle and a catheter into your leg, into the blood vessel, there's risk of infection. If your skin has infection, there's a risk of bleeding because I'm in a blood vessel, and then there's risk of blood clots. The blood clots are a bit different though. These are superficial blood clots. These are not deep blood clots. So we don't put you on anticoagulation. If you get a small blood clot, you get aspirin, and sometimes if it's so small, we don't do anything. How do we know that? Everybody who gets an ablation, we scan them in a week to go and look and confirm the vein is ablated and there's no blood clots. So this is schematic showing the procedure. So typically we try, and most people will have, if they have bad reflux that I think they should get treated, they will have reflux from up here. This is your junction. So it'll be leaking backwards. It'll tend to usually go all the way down, at least below the knee, okay? In some people, I see it actually down up to here, but most people will have reflux in this segment. So we find a part of the blood vessel that's good size around the knee or below the knee. We put a needle, numb your skin, and then we access it with a little sheet. This is a sheet sitting in your blood vessel. This is the catheter that we then introduce, and the catheter goes all the way up, and we park it right here. You see here it says 2.5 centimeters. That's important because this is your femoral vein. That's a deep vein. We don't want to burn that. We want to burn this vein. Because if I burn here, that's not good because I want to restrict the blood flow in your deep veins. So we take pictures to confirm this, and we save a picture on the patient's chart showing that we were at least 2.5 to 3 centimeters away from that deep vein. Then an additional step we do once the catheter is in, now this is skin. This is skin around the vein. If I give you a heat treatment, it's going to hurt if I don't numb up your skin. So all the way from here to down here, I have to put several spots of lidocaine into your skin so that the area around the catheter has lidocaine. You don't feel anything. So in summary, venous disease is due to venous insufficiency. It's a common medical problem. Be aware of the risk factors. So avoid prolonged standing, making sure you use your calf pump your legs. Some of the symptoms to watch out for that should make you alert yourself to think of getting it evaluated are pain, fatigue, heaviness, swelling, skin changes. This is something that requires a comprehensive evaluation, and in some cases requires involvement of a wound clinic, because if you have venous ulcers, you need wound therapy afterwards, okay? Compression, elevation are just as important as the ablation. And that's it.
Beth, do you have any questions in the chat room? Nothing currently, so let's use the room first. And if we could, when a question is asked, if you could repeat the question, that'll help for the Zoom.
You got it. Doctor, why do you think it has been somewhat untreated and unrecognized up to this point?
I would say it's based on us focusing on more vital organs. I think, we look at people's legs and say, okay, it's not going to, it's not going to cause mortality. You're not going to die from this condition. So most of us, given the constraints of time we have, in my office for the last 5 years, like I was focusing on making sure the heart's stable. There's no AFib, no heart failure. The legs came last until a few years ago, I went to Orange County to see a doctor who was well known out there, was treating these patients. And initially, I'll be very honest, I thought, oh, this is just cosmetic, it's going to make it look good, feel good. And when I met the patients who had been treated by him, who were coming for follow-up, some of them had life-changing. So they were like, I was in pain for the last 3 years. And everybody said, it's just old age. And having that ablation made a big difference to how they felt.
Question?
Hi, thank you very much for your presentation. I'm from Canada, so if I had the procedure done here, I'd have to pay for it myself. Do you have an idea of what that would cost?
I don't have the cash pay number off the top of my head, but that is something Eisenhower Financial can easily get for you, because right now, because I don't do any cosmetic stuff, we are only doing through Medicare or private insurances. Typically, what I've been told though, an ablation is for the whole procedure, because it requires the kit, the catheter, the compression bandages and everything. I think it's about $2,000.
I have had one vein that they tied it off in my one leg, so I have had the issue. I tried contacting the Desert Vein Institute here, but for some reason they wouldn't return my calls, and we're going home on Monday.
I see.
We're planning, if everything goes well, to come back in the fall. Would leaving the veins, I know you can't say for sure what I've got, but leaving him for 6 months, would that be a major issue, do you think?
It depends on the severity. So like his question was, will leaving the veins untreated, if you have this issue for 6 months, cause problems? If you have venous ulcers, yes, I would say don't delay treating them. If you have some edema and some discomfort, waiting 6 months is not going to hurt. Okay. But in the 6 months you wait, it's going to be crucial for you to follow those supportive measures. So making sure, especially if you're traveling long distances, compression. I know people don't like it because doesn't look nice, but the compression stockings make a big difference and keeping your feet elevated, which is why you notice in the morning when you wake up, that's the best your legs look, because you've been against gravity the whole night for 8 hours. And then when you stand up, it starts getting swollen.
Do you have a card after the presentation?
Sure.
Thank you.
Oh, I have one question as well. You were talking about compression. Is there any other preventive maintenance that someone should do to themselves just when they're home or during daily life?
Exercise. So, that pump is your calf muscle. So if you do exercise where you're walking, you're pumping your calf muscle, that'll help prevent or delay this condition. Exercise plays a crucial role in pushing that blood up through your legs into your heart. I saw a patient today for a venous consult. He had swelling 2 months ago. He came to see me today and he had zero swelling. And I asked him what he did. He said he was at a lab appointment, and a lady told him, hey, I had that, start pumping your calves every day. And he did that, and the swelling went away. And at that person, I told him, you don't need treatment right now because your supportive measure work. There's no need for me to go and burn a vein if your swelling completely disappeared just by exercising your calf muscle.
Getting my exercise, my veins are good.
You're doing well. Yes, maybe I should be doing the walking. Is it common to have it in one leg and not in both?
It's not common. Typically, most people tend to have it on both legs because, the pressure comes from just not one leg, and also it's from, your heart your leg has two veins, but they drain and they join a common vein in the middle that goes to the heart as a single vein. So typically, if you have one on one side, you can have on the other side.
Okay. Because my left leg has been a problem for
Typically,
years.
so you may have different severity in one leg. So some person's right leg might have disease, but it's not severe reflux and they have no symptoms. The left leg may be much more severe.
Okay.
And that is common actually.
And then is there pain in the calf muscle at all?
Yes.
Without exercise? I mean,
You,
just,
so that's a big
sitting.
red flag. If you get pain in your calf muscle, that's a very concerning sign for possible venous disease.
thank you.
I had a ultrasound back in August at the Sunrise location, and they didn't notice anything going on. I just had an ultrasound a week ago, and I've had a lot of the symptoms for the past year. Had it done a week ago, and suddenly there's, yes, they do note reflux, and it's in the locations that you mentioned. But the ultrasound that they did in August, I was laying completely flat for the whole ultrasound. This time, they had me tilted. Should they be doing it tilted so that it simulates having to pump?
Right.
Okay.
So the question is, when you get this evaluation done with the ultrasound, does the position make a difference, whether you are laying or standing? Very good question. So when you do the ultrasound, right, most typical ultrasounds of your lower legs, when people order them, they're not looking at the superficial system, because most ultrasounds are done to exclude blood clots in the deep system. So, I've done thousands of venous ultrasounds before I started doing this procedure, and none of the previous ultrasounds even mention the superficial system, because the technicians get an order saying, rule out DVT or leg swelling, because the common understanding was, if you have a clot in your deep system, your legs are swelling, that's life-threatening, dangerous, needs anticoagulation, rule that out, okay? So that was the priority always. So if somebody orders just a venous ultrasound, they're gonna lay you flat and look at the deep system. There'll be no comment on the superficial system. So when we order in our office, we say venous ultrasound for varicose veins. That then they know, okay, they don't even, they just superficially, they just take a quick look at the deep system, but the entire study is focused on the great saphenous, the small saphenous. And what they do, like if I tell the technician this person has pain and swelling, they lay you down and do the scan. If they don't see anything, they'll actually make you stand up. Stand up for a few minutes and exercise your legs and scan you again.
Thank you. I'll be contacting your office.
I don't know if you could pull up that slide that you showed the veins themselves.
Sure.
Yeah, the saphenous vein.
So while they're pulling it up, I'll say one thing that has to be kept in mind, okay? Whether it's an ablation, whether we are injecting glue, whether they're doing surgical stripping, what we're doing is shutting off the superficial veins. And that's because most of us still have the deep veins. So through the branches, the blood drains from your skin to the deep veins and up to your heart. The superficial vein doesn't go to your heart. It has to drain at some point to the deep vein. And most of the time it drains at that junction, and that junction takes it back to your heart. This is a relevant thing to keep in mind in younger patients, right? So if I have a 40-year-old patient who comes to me because their legs are just having trace edema, they got a lot of just varicose veins, but they have zero symptoms, I actually don't encourage them to treat it at that age, because if they truly have no symptoms, they may need that vein if they need bypass surgery. And that's important to keep in mind, okay? In our population here, we can do stents in most people, but if you're a younger person, if you're 40 and you have multiple blockages, we recommend surgical bypass over putting stents in. So when the surgeon needs bypass, one of the blood vessels he looks for are in the legs. For most of them, he can find it because he just a small segment, but it's a discussion I have with younger people. Hey, You have disease, but keep in mind that we have to only burn what we have to, not the whole thing. And sometimes we just select the areas we need to burn for that reason.
So you mentioned earlier that they harvest the veins for bypass
Mhm.
below the knee. Is that correct?
Correct.
Okay.
Most of the time it's below the knee unless the veins damage below the knee.
Yeah, I know in my own case, it was from here to there.
Exactly,
Yeah. So what happens to the leg in terms of this flow of everything once they harvest that particular vein,
So
where
the
they shut it
reason-
off or whatever they
reason
do?
They harvest it, and the reason why we have no fear ablating it, because essentially we're doing the same thing. In your case, they took the vein out, you don't have the vein anymore. In ablation, collapsing the vein is because you have so many branching veins that go into the deep vein. Like nobody will ever remove a deep vein or ablate a deep vein because that's going to cause significant issues. Because if your deep veins don't drain, your legs will swell up huge, which is why so people with deep vein clots, if you've had blood clots in the deep veins, one of the complications is you get swelling, and that's very hard to treat. And ablation doesn't fix that because it's an issue with the deep veins. Your deep veins are damaged. The venous disease I'm talking about is a superficial vein. Superficial veins don't play a big role in the complete drainage of your legs.
Another question I had was the glue that they're using. I seem to use the same stuff when I fix my model railroad train. So is it the same kind of
It's very
stuff?
similar.
It's-
No, it's a different glue altogether.
And you get it, you can really stick your fingers together with that stuff.
So
Oh
like
my God.
there's so many new things coming through for this condition because I would say probably in the last 5 to 7 years, venous disease got much more attention because so many people notice it. More people have a lot of pain and swelling. So there's a lot of new treatments coming through. Ablation's been a mainstay of treatment for the big veins, but there are some, interesting new stuffs coming like clue little plugs. So, it'll be interesting to see how we alter our treatments as we progress this journey. At Desert Cardiology, we didn't have this option before. All of my patients would go out to get this treatment. So we are starting with the bread and butter standard stuff. And our hope is if we see the need for it, we'll try and introduce newer stuff that's as they become available, if it's better than the ablation technique.
Thanks for informing us tonight. This has been great. Overall, or to this date, is there any evidence that COVID has affected heart issues and vein issues? And is there anything going on with that and research or?
So I can tell you with regard to COVID, the manifestations of COVID in your heart and in the vascular system, the ones that are proven for sure that we see an association, right, is we have seen people have heart attacks from COVID because blood vessels in the heart, the plaque can rupture from the inflammation. So when you have a plaque in the coronary arteries in your heart, that plaque can be a 40% plaque sitting quiet, you have no symptoms, okay, you are going about your day. But if something in your body changes the dynamics in the blood vessel and causes inflammation, that plaque can rupture, which is why one of the risk factors we talk to our patients about is stress management. When we are stressed, it causes inflammation in your body. This is a well-known thing. You see 30, 40-year-old healthy people dropping dead of heart attacks because they had a 10% plaque. Now they are stressed about work, about family, and they have significant stress and inflammation. Stress causes certain chemicals called interleukins and TNF to be released into your bloodstream. Those destabilize that plaque. Your plaque has a little cap on top. If that cap ruptures, cholesterol spills out and you get 100% occlusion. So based on that theory, what we've seen is COVID is a stress reaction. COVID causes stress on your body, causes inflammation. So if COVID is causing inflammation in the blood vessels, can it rupture a plaque? Absolutely. Have I seen it in my patients? Absolutely. The other thing, the more common thing though, actually is something called myocarditis. Okay. So your heart muscle is different to the blood supply. So, I tell my patients, your heart has a pump and your heart has plumbing. Plumbing is heart attacks. Pump issues is congestive heart failure. So we see more pump issues. So people getting inflammation of the heart muscle. And that's because if your body has COVID, your immune system will sometimes create antibodies against that virus. Sometimes your antibodies mistake your heart muscle, and there's interactions between the virus and the heart muscle, and the antibodies starts damaging the heart muscle. And we call that myocarditis, inflammation of the myocardium. That's the most common significant cardiac complication we've seen, and that can be actually life-threatening. Okay, that's something that can be mild, and they have chest pain, and we see no blockage, but we see the troponins go up, the heart muscle looks inflamed, we may see a bit of fluid around the heart. Or it can go on to fulminant congestive heart failure, where the heart the pumps just starts failing completely. The other thing we've seen most in younger patients is something called autonomic dysfunction. So your brain has two neural pathways, one called the sympathetic and one called the parasympathetic. Sympathetic is your, the stress response. Parasympathetic is your happy response. You're sleeping, resting, that's your parasympathetic. COVID tends to dysregulate that. So how does that present? You will see people with a resting heart rate of 120, 140. The pressure is going all over the place. So that's something that I've seen a lot in younger people. After COVID, they may say for the first 6 months to a year, their heart rates are all over the place. Their blood pressures tend to go up and down. Okay. And then the third thing is blood clots. So it doesn't cause, we haven't seen any relationship with COVID to what I discussed about superficial venous disease. We've seen COVID cause deep venous thrombosis. A lot of patients with COVID got blood clots in the deep veins and in the heart and the lung. So like when at the peak of COVID, I went and worked in the ICU for a couple of weeks, and I was seeing people's arms and legs completely thrombosed black because they were having clots form. And that's because it causes inflammation and your body starts clotting uncontrollably. Those are the main things we've seen with COVID.
Well, this may qualify as no question is a dumb question, and I apologize in advance. Is inflammation medically visible or calculated? Because inflammation is just something that still is somewhat mysterious in my mind about defining it and understanding it, and it seems so important.
Correct. So, and I think that's the main reason why heart disease is still the #1 killer in the USA, because we don't have good markers of inflammation that are specific to your heart. Can you measure inflammation? Yes, there are certain blood tests. There's something called a CRP, or a high sensitivity CRP. There's something called a homocysteine level. Those just show inflammation in the body though. But say you have a cold last week, or you had a virus last week, it's going to be high because you're inflamed. Say you have a cancer, it's going to be high. Say you have rheumatoid arthritis, it's going to be high. So the inflammatory markers we have are not specific to the heart. And that's the problem. We don't know, is the inflammation in the blood vessel or is it in an organ? And that's why we don't have good treatments for that. So, there's been a lot of research in vitamin E, the antioxidants. This were all the premises to try and treat the inflammation. There's been no big breakthrough because it's hard to tease out how do we target inflammation in the blood vessels. There are some scans that we do that help us a bit. So like, I tell people men over the age of 40 and women over the age of 50, if you want to check your heart out to know if there's plaque, we do something called a CT calcium score or a CT coronary angiogram that shows plaque in your heart, and that's a good starting point. It's basically certain chemicals in your body that cause the blood vessels to start deteriorating. Thank you, guys.
Dr. Wick, thank you very much. That was really outstanding.